So welcome at the meeting. For those who haven't met me, I'm John McDonald, the chair for Kettering and Northampton. And apologies, we've had a few. Chris Welsh, Andrew Moore and Trevor Shipman. And the governors for Satcher, this was Amy Wells, Chris York and Peter Williscroft. So I think, I forget who was taking the lead from Peter at this meeting.
It's Mabel.
Mabel,
it's
is
Mabel.
it?
Right.
Meant to be Mabel
Sorry?
Blades.
Right, okay, sorry about that. He did send me a note for that. So it's Mabel, I can't see her on the screen, but is she here? Let's have a look.
She's not joined yet, John, but she should be here. She'll be with us shortly.
Right, do people feel we should wait for her, or would they like us to just carry on? I mean, we've just got a bit of sort of routine admin-y stuff to do at the beginning, haven't we, in terms of minutes and things? So shall we work through those, and hopefully by the time we get on to the substantive items.
I think she had a problem trying to join in, Richard.
Okay.
Yeah.
Okay. Well,
Start, John. Yeah, start.
Yeah. Okay.
Let's
Thanks.
start, yeah.
Just one thing, which I think you've had the updated papers. We had intended to bring the external auditor's report here, but that's been delayed slightly. There's a few more details still to be agreed, so that's been put back, and likely to be a subsequent meeting later on this month for you to see that. Okay. Right. Item 2 then, minutes of the previous meetings held, first of all, on the 7th of June. Any comments on accuracy there? Richard.
I've missed Mo Latif off the list of apologies, so my apologies. That will be updated. Thank you.
Okay, thanks. Sorry about that. Okay, so minutes of the meeting of the 7th of June, an accurate record? I'm not seeing any hands, so I'm going to assume, Mabel arrived, great. Morning, Mabel. Nice to see you. We've only just started, okay? If that's all right. We're literally just got to the approving the minutes of the meeting, just to bring you up to speed. Okay, thanks. Meeting then of the 5th of July. Any comments there on accuracy? Again, I can't see any hands raised, so I'll take those as an accurate record. And there are 3 open actions on the log, all being progressed. Does anyone want to ask any questions about any of those 3? Again, I can't see any hands up, so I assume you're all happy with that. Thank you. So, Debbie, can I hand over to you?
Yeah, thank you, Chair. Good morning, everybody. So I have got 4 areas to talk to you about this morning. If I go through all 4 areas and then we'll do some questions at the end, if that's okay. I'm going to start off with performance. So our operational performance, I'll start off with our elective weights. We are currently in a really good position with our elective weights. So this is outpatients and inpatient electives. We are amongst the best performers within the region, which is really good news for our patients. The national expectation is that we have nobody waiting 65 weeks from March next year. Now, that does sound like a long time. We are expecting to be able to reduce our wait significantly below that by next March. But what I will say at this point is there are a lot of NHS hospitals in the country that have patients waiting much longer than we do. So for our patients, we are currently in a good position, but we need to do more to be able to reduce those waits. In terms of our cancer performance, so our 28-day faster diagnosis, so this is the target where we have 28 days to be able to diagnose our patients. Again, we are consistently delivering this target. We're in a really good position from this point of view. Again, one of the best in the region. What I will say here is we are then not as good at them bringing those patients in for their treatment or their operation. And throughout the last several months, we've built up a little bit of a backlog of patients who were waiting then over 62 days for their treatment. We're now starting to really reduce that backlog. It's coming down quite nicely. But what that means is our 62-day target, whilst we are treating those patients, is not being delivered and is unlikely to be delivered for a good few months until we can reduce that backlog of patients. We do make sure that all of our patients have had harm reviews when they come in and see our consultants, just to make sure that we are not causing harm through those long waits. In terms of diagnostic performance, so our diagnostic performance, this is radiology, endoscopy, some cardiology investigations. We've had extra capacity because of the community diagnostic centres, which is having the desired effect. Really good amount of capacity being put into place there. So we are still expecting to hit the 85% target by March. That's a nationally mandated target by March next year. And we'll have 85% of patients being diagnosed with radiology, cardiology, endoscopy within 6 weeks. So good performance so far. I'm not particularly concerned about this, especially with the increased capacity through the community diagnostic centres. And we're also putting some additional capacity in place with our cardiac MRI scanner over the autumn and winter. So that's our operational performance. A&E has been, dare I say, reasonable over the summer period. We have started to see an increase in activity this week. And we've also started to see an increase in patients coming with COVID. So Peter had asked me to update you on COVID, actually. We've seen no impact of COVID over the summer, but we have over the last week started to see a number of patients coming in to specifically outpatients, actually. So patients coming into outpatients with some symptoms, but also outpatients cancelling their appointments because they've had COVID. We've currently only got 15 patients in our hospital. But that has increased over the past week from around about 8 patients to, as I say, 15. The numbers of our colleagues at Kettering with COVID who are at home isolating has not changed over the last month and a half. We've seen no effect with regards to our staff. But I'm sure that you will all know of somebody in the community at the moment that's got COVID. So I would say it's definitely back on the agenda, but at the moment it's business as usual for us. One of the areas that we are not doing particularly well on at the moment is our financial performance. So for July, I will give you some numbers now. We were planning a deficit of 3.6 million, and we delivered a deficit of 5.7 million. That was predominantly due to 3 areas. The first one was we didn't achieve the number of efficiencies that we had planned to. So this is our cost improvement programme. The second one was the increase in inflationary pressures, which I'm sure you will be aware of. As an NHS, we suffer that just like you do in your own lives. And also the impact of industrial action. And that continues to be a challenge for us over the autumn and the winter. I'm not seeing any solution or plan to end the industrial action for our doctors as yet. So I expect that will continue for some time. In terms of what we are doing about finance, so we are currently working on a reforecast for the year end. We're doing a lot with our colleagues throughout the whole hospital at the moment around efficiencies and what more we can do to save money and also be more efficient. We've held several workshops in that regard. And we're also working on our medium to long-term financial plan, because I think it's really clear that we will not be able to clear this deficit within the next year or two. So we will need a plan for the coming years to be able to move that deficit to a break even. In terms of the leadership team, so this is an area that I would normally update you on. We have got a new Chief Finance Officer who is starting with us on Tuesday next week. That's Richard Wheeler. He's worked at NHFT, the Mental Health and Community Trust, for several years. He has got experience in acute and also ambulance service. We're really looking forward to him starting. So since John Evans left, we've had Helen Ellis, who's acted up. So she will step back down to being deputy when Richard starts next Tuesday. We have recently been out to advert for the Kettering Director of Estate. So David Pickett, who you know, is currently on a fixed term contract. He's not able to stay with us. He lives in the north of England and travelling is getting quite difficult for him. So we advertised. I thought it was a really good field. We shortlisted 5. We interviewed 3 candidates. Unfortunately, we did not appoint, which is really disappointing because I did think that it was a good field at the time. So we will go back out to advert again in October. David has agreed to extend his contract with us to make sure that we have got cover until we can get somebody in substantive. And then the other person is Susie O'Neill, is on mat leave now. She's had a little baby girl, and her cover, Sam Holden, starts with us on the 2nd of October. And again, really looking forward to Sam starting with us, and he will be the Group Director of Comms and Engagement. In terms of our estate, this is the 4th area. You'll be pleased to know I'm nearly there. Sorry, lots of cars outside today. So start with the lower site development. This is the multi-storey car park and the movement of the substation. That's the substation for incoming power being relocated because of the new car park. So in terms of that development, the full business case is now expected to be complete by March 2024. That has been delayed, but mostly, in fact, all delay has been through the National Hospital Programme. And that's because the financial approvals from NHP, the hospital programme, had been pushed back somewhat. So we're working on that. We've got partners engaged, we've got power, we've got water all engaged with us in terms of the enabling works. The other area of estate is our urology one-stop clinic, which some of you will already know about. This is expected to be complete in November this year. We've invested 2.1 million in our urology one-stop clinic. This is going to be a fantastic service for patients because at the moment we have people come into our urology clinic on several different days for several different tests. What this will mean is they can just come on one day, have all the tests, start some treatment potentially on that same day. Will prevent them having to keep coming back to the hospital. So I'm really looking forward to that being open, and it'll also help us to deliver our urology cancer targets as well. And then the other area that's just adjacent to the urology area is our Crazy Hats waiting area. Crazy Hats is the charity that was disbanded last year. They've donated a significant amount of money, John, over the period of 20 years, with millions of pounds actually. So we've invested 400,000 from their charity for a new waiting area and courtyard, and that's predominantly for our breast care patients, and that will also be due to complete in November this year. So there's a lot of information there. I'm conscious that I've bombarded you with a lot, but I'll stop there and happy to take some questions.
Jane.
Yes, good morning, everybody. Thank you,
Morning,
Debbie.
Jane.
Just a few things. You mentioned the cancer wait from diagnosis and backlog. I'm sure you're aware that if you're a cancer patient, having the diagnosis is drastic, having to wait to start your treatment must cause enormous psychological damage. Have you an idea what the backlog is due to? And secondly, COVID, is a new variant making its presence felt at Kettering General Hospital yet, or is it still the old variant? And are you ensuring that all the nurses and doctors are having their new vaccine? Thank you.
Wow, there's a lot there, Jane. Thank you. So if I start with COVID, so COVID, I don't know what variant we've got at the moment. We generally are not aware. Right at the start of COVID, we were aware of the variants that were in our hospital, but we don't treat patients any differently. So I'm not aware, but I will find out. In terms of our COVID vaccine, that's going to be starting within the next month, along with our flu vaccines. We will do the normal stuff that we do in terms of encouraging our staff to have their vaccines, both flu and COVID. But again, it's not mandated. You know, we've all got our own opinions on this, haven't we, in healthcare? But we will be doing everything to encourage our staff to have the vaccines. In terms of cancer, so a few areas actually that are impacting us with regards to our 62-day wait. Urology is one of them. Haematology, oncology is another one which we're working with Northampton on to address. And I think you're right, the psychological effect once you know that you have got cancer is fairly big, isn't it? And certainly not where we want to be. Hence the reason why we are now starting to see a reduction in that backlog, putting some additional capacity in place. We've got the urology one-stop where patients will come be treated with either hormones or watch and wait, for example. So I expect to see that backlog continuing to come down, and we are making sure that we keep in touch with those patients to offer support as required. Thank you.
Mohammed.
Oh, hi. Thank you very much, Deborah. I second the last sentence you said about the cancer patient, is that if they're going to wait, just keep communicating with them, reassuring them, and getting the consultant to communicate with the family. That is a very good positive for people who have to wait. I was just asking because I hear a lot about schools. Do we have an Iraq problem in our hospital establishment? The other progress so far is reading through the minutes of the meetings in June and July. There was a problem about race and also a problem with discharges and the discharge passport. What's the progress in that as well? Thank you.
Yeah, thanks, Mo. I didn't quite get the question about schools, sorry.
Oh, the RAC.
Oh, the RAC, sorry. Yes, yeah, of course.
Do we have it in our buildings at all?
Yeah, okay, thank you.
Is it a threat to our wards? No.
Yeah, okay, thank you. So we've done a full, I'll start with RAC actually. We've done a full survey of our buildings with regards to RAC. There's one area that we are doing a little bit more auditing around, which I expect will be done within the next couple of weeks. But so far we are clear, completely clear of RAC. But I just want some more assurance on one of our areas. Just remind me what the other
yes,
questions were.
The second one, reading through, I was a bit alarmed about the fact that race exists amongst the staff in Kettering General Hospital. And the third one really is the speed of discharge and the discharge passport, which will be a great achievement, really. Thank you.
Yeah, thank you. Sorry, I should have written those questions down. So in terms of race, we know that our race standards, our RES standards are not where we would want them to be. I would be really naive if I thought that we didn't have racism in this hospital, and we do actually. And I was really clear at the last trust board around this. We've got an anti-racism policy and plan in place. We've got a lot to do in this area, not least for our staff, but also for the local community, because I'm also conscious that there are people in our local community who see our hospital as a racist hospital, and that it's difficult to say, actually. I feel quite embarrassed saying that, but what's important is that myself and the trust board are really clear that we have got a problem and we need to address this. We need to address it together, because I don't have all the answers. So there is a lot to do in this way, but we have started the work on this, and I am really clear that if we have racism in this hospital, then we have got to address that and take a really quite hard line, and that's with patients as well, because we have, in fact, we have more patients who are racist towards our staff at the moment than we do staff towards staff. So it's both ways.
Can I come back on that, please,
Of course.
Deborah? You cannot really treat race with hard line. It has to be a soft approach, really, and to inform the existing staff that newly arrived people are a little bit more sensitive, and just give them enough communication, make them feel valued. That is the key, really. But to take a hard line, you make people more polarized, if that is a word. In fact, I mean, race is a something sensitive and should be treated in a soft manner. Thank you.
Thanks, Mo. So we're taking some direction and support from our Reach network. I still feel concerned. No, that's the wrong word, actually. This is a priority for me. If we have colleagues with an intent to be racist, then I will take a hard line. What is really important here is that we support our international trained colleagues. We support all of our colleagues who have protected characteristics, regardless. And we do some really good, strong education and learning with the whole of our colleagues in our hospital. I think that's the most important thing, but I do understand what you're saying. In terms of discharge, so speed of discharge is a constant challenge for us, especially for those patients who require pathways 1, 2 and 3. So this is either care in the community or care in a care home. At the moment, our pathway 3, those patients who are waiting nursing home and residential homes, they're the people who are delayed for the longest periods of time. We're working with Northants social care team with regards to the old specialist care centres, Thackley Green, to see what we can do to be able to open some additional beds within Thackley Green, especially for patients who have got dementia or delirium. The patient passport, I'm not too sure where that's up to at the moment, but I will get an update directly for you, Mo.
Thank you. Thank you very much.
Thanks. Mabel.
Thank you very much. People often complain about A&E, but I was stung by a hornet on Saturday and I've reacted so badly I had to come to A&E on Sunday. I was seen within the hour. Children were being seen quicker, and in that hour I had an argument with the doctor I saw because he wanted to admit me and I didn't want to be admitted because I know how sure you are of beds. So he offered an alternative, but it isn't all bad. The other thing, may I ask a question? You were going to have a meeting on efficiency savings. Could we have some highlights, please, for the governors?
Yeah, of course. So at the moment, we have identified around about 60% of our efficiency target, Mabel. We've held 3 workshops so far with our divisional leaders and then 2 other workshops with colleagues that were invited throughout the whole hospital. We have now got a list of about 70 different things that we may want to do. We're just working through prioritising those, but that gives us an estimated between £5 and £7 million worth of additional efficiencies. I don't expect that we will be able to put all 70 in place, but what we will need to do is just work through, which is what the finance team and the ops teams are doing. So it's things like reducing the number of times that we print, making sure that colour printing is switched off, doing things with regards to the electric, making sure that lights are not on. So there's some really simple things in there, but there's also some fairly big things around job planning for our consultants, for example, and also making sure that we've got job plans for our nurses, especially the specialist nurses.
Thank you. Could that list be shared with the governors so we can look and see if there's anything we can support? Thank you.
Yeah, thank you.
Thanks, Mabel. Rashmi?
Hi, Debbie. Yes, one of the things that it is good that I'll just make comment that elective outpatient, performing better than nationally. But again, is there in that context, we performing, but how we doing with the staffing in terms of, because like within, again, efficiency, we keep saying, and the performance. So how we going to, match the two, although we're doing better, but is it where we can, in terms of efficiencies, whether we are able to do anything different in terms of, staffing? And I think I'm more concerned like culture, racism. And part of that one is, again, you mentioned about the community perception. And I declare interest that I am involved, one of your Northants organisation, voluntary sector. And within that, from discharge, some of the cultural or understanding when you are discharging patients, whether through Northampton and in hospital later at night. And I think how you are really engaging with your discharge program, because unless you are bringing part of the especially cultural differences, we are not going to see the differences. So thank you. I just want your views on that. Thank you very much.
Yeah, thank you. So if I start with staffing, so you will be aware that our headcount has increased in our hospital over the last 3 years, quite significantly, and that was predominantly due to COVID, but also some of the services didn't have enough clinicians to start with. So this is also about making sure that our services are safe and being delivered safely. We have got 8 work streams, one being led by the Director of Nursing, one by the Medical Director, exactly with a view to looking at our staffing and making reductions as and where we possibly can. We've already done an admin review, and this is predominantly band 3 and band 4 admin who work in our clinical divisions, and we're taking out £500,000 just within admin. That's full year. So we've started the work, Rashmi. I think with the whole of our efficiency, we've done all the low-hanging fruit, so to speak. So the things that we are now doing are the more challenging areas. Culture and racism and discharge, I think it's a really good point you make, actually. I think we've had conversations in this regard before. We've got a new discharge matron who is really keen on pushing this forward. So watch this space, I think, is what I would say to you at this point.
Can I just make a point again? I raised one, some maybe from of other meetings, that when you commission the new discharge program as a, within the new commissioning, and I raised that why are we not really bringing as a partnership delivery, bringing the cultural organization we have got within the county part of the delivery. And we are, and I've been involved now nearly 2 years now, and I'm bringing this to the attention. And when we, fairly recently commissioned that services, and we're still not really thinking outside the box and taking the opportunity. Thank you.
Okay, thank you, Rashmi. I think it would, I need to just understand a little bit more from you. So should we have a conversation maybe after this, maybe later this week, just to talk about where we can tap into in the community, because we're clearly missing that element. I want to make sure that we're hitting the spot, so to speak.
Sorry, Anu?
Thank you, Chair, and thank you, Mo, for picking up the racism issue. Thanks, Dave, that you have got the plan to tackle the racism. I wanted to point out that there is maybe two kinds of racism. One is direct, and the second one is the indirect. Indirect one is very difficult to identify. I'm one of the unity counselor in this division, and so many, I've got so many KGH worker in my division. They say that their managers, they might not be like very openly racist, but when they are scheduling the shifts, they are always put on very difficult shift where their colleagues, they always get the very easy shifts. I asked them to give me like a written complaint, but they're not happy to give, and they believe that you and the KGH management team knows about the racism issue. So that is one thing. Second question is that, do you have any like a detail how many departments in KGH do not have sufficient doctors or staffs? Can you please share that with us?
Thanks, Anu. I'm not sure. So I definitely haven't got that data with me around the doctors. What I do know at the moment is if we take the whole of the number of clinicians that we've got in the hospital compared to others, we are quite well off, but that's not at specialty level. In terms of the indirect racism, I think that's really important. And there's two things there. The first one is culture. And you said that we have got colleagues who perhaps don't want to speak up. And some of the work that we're doing along with racism and anti-racism is creating that safety, that psychological safety where colleagues do feel that they can speak up and that the executive team are acting on it. I've heard previously that we have staff members who are moved because of their colour, because of their race. And when we've looked at that previously, we haven't been able to quantify what is being said. So if you've got some specifics, I would be really keen to just understand what they are and try and get under some of the detail of that, please. Please drop me an email.
Chair, if I can come back again on this. It might be a good idea to carry out an audit to find out what kind of shift this migrants worker are put and what kind of shift other people are put on.
Yeah, if you've got anything specific, Hannah, I would be really keen to understand it.
Yeah, thank you.
Thank you.
Thank you. Sheila?
Yeah, it's going back to discharge again, Debbie. For Healthwatch, I go to the people advisory group for ICANN, and we have shared the patient passport with Claire. Actually, she's kept us up to date with the work that she's been doing, which I commend. But the thing that I wanted to speak about was Fackley Green. Now, there is a similar establishment in Rushton, Spinneyfields, and we have been assured at that people advisory group that it is going to come back into use, but they are doing alterations in their, actually, because they're all single rooms in that building, and what they're doing is knocking down some walls so that one area can have 5 beds in for people who need monitoring more constantly. So my question is, have you any idea when it's going to be ready for use? Because that's going to give you another 52 beds.
Yeah, no, completely agree, Sheila. So I don't have the timescales on me, but we are working with North Northants because there is an opportunity there for their registration to potentially change and for us to be able to support with our colleagues, with staffing. So potential for rotation of staff. But I don't have the timescales.
That's a shame, because that would be a great asset, wouldn't it?
I can come back to you on that.
Thanks.
Thank you. I've got 2 more questions. So David and then Jane. David?
Thank you, Chair. Deborah, I just wanted to raise one question based on an observation from one of the LET talk sessions last month. It was the one where there was a discussion, read the sessions on dementia awareness and so forth.
Okay.
And one of the staff members raised an issue that they felt that certain aspects of it were a waste of time and they could do more and so forth. And another member of staff explained that that was actually part of the training session.
Yeah.
You remember it? Because
this was the dementia bus.
Yes.
Yeah.
The thing that struck me about that was that it seemed to me that there had been, with that particular person, potentially with others, there had been a learning opportunity that was actually missed because the circle hadn't been completed in terms of ensuring that the learning outcomes had been achieved. And it resonated from both a previous session that I attended on serious incidents where training was raised, and also had echoes from the previous CQC report with regards to falls. And I just wondered whether, one, that had been picked up in terms of the conversation at that session, and whether the preparation of training actually has anything in it to actually ensure or carries out a test to ensure that those training sessions actually do close off that loop to ensure that those learning outcomes have been achieved. So that was the observation and the question. So I'll leave that with you. Okay.
Yeah. Thanks, David. I think you're absolutely right. Jane Skipper, our Director of Nursing, took that action away with regards to the learning outcomes, and especially the communication up front with regards to the dementia bus. So I will ask Jane to just make contact with you, just to give you an update on where she's got to with it. She's off this week.
Jane?
Yes, thank you, Debbie, for letting me come back again. I had one item for you, except for when you were doing your reports, I wanted to come in on the COVID, obviously, and the cancer. I was reading the audit report, audit committee on the 23rd of June. And being somebody who knows, who keeps being told by everybody that digital is very, very important, this was very disturbing. It said, Mr. Moore, I assume he's a non-executive director, was surprised for the reasonable assurance noted under digital and asked how this was agreed. Mr. Apps advised that the risk had been well articulated and the issues clearly described. Mr. Moore challenged whether the description was correct. He referred to the annual report and whether the trust was presenting a true and fair view on its digital responsibilities. I would just like some clarification on what that exactly means when we're talking about joining our digital resources with other hospitals as well. Thank you.
Yeah, thanks, Jane. I know that Alice has just popped her hand up, and I wonder whether or not Alice, as the audit committee chair, wants to come in at this point. I didn't attend that audit committee.
Yeah,
Alice.
that's fine. Very happy to, Debbie, and thank you, Jane. Yeah, the point of clarity was when we were reviewing the draft annual report, Jane, and there was a comment regarding the assurance we had over the progress of the digital strategy. Andrew Moore, who, yes, absolutely is one of our KGH non-executive directors, said that he felt the wording was too bold, if you like, in terms of our assurance. Richard's clarity was quite right technically, that the wording was saying we are assured, i.e. we are fully aware of where we are in the plan, where's good and where is not good, if you like, in the strategy and the plan for digital. But we still felt the wording was a little bit too bold. So the action taken away from that was that Natasha, Debbie, and I believe Richard, one of the two Richards, toned down that wording. So we were less, sounding less bold, if you like. And I think as former chair of the digital committee, I'd probably say, we've talked about this before, there are certainly areas of digital we need to do significant work in, and we're not hiding those, if you like. But we know where they are. I think it's a case of knowing your issues, if you like. Does that make sense? Thank you, Jane.
Thank you very much. I'm assuming, Anoop, that that's a residual hand, or do you want to come back on something? I assume it's a residual hand. Okay, shall we move on then to the committee summaries? So first of all is the clinical quality and performance. Both Natalie and Simon Bayliss here, Natalie Armstrong, Simon Bayliss. I don't know who wants to go first, but can I leave that with one of you to come back and report on that? Thank you.
Yeah, so I'm happy to start. Simon, do add anything if you want to. So within your packs, you will see that you have the upward report to the Board of Directors for the Quality Committee meetings in both June and July. So I won't talk through them in a huge amount of detail. You will see that there are a good number where we have reasonable or substantial assurance. The exceptions to those, so on the June report, we have a limited assurance around breast service collaboration. So if I recall correctly, this is largely around breast reconstruction surgery and where that is happening for patients. So the limited assurance, I think, for that is largely because that we are still waiting for some further updates on that from our medical director, John Jameson. So he's going to be doing some further meetings with clinical colleagues through September, and you will see that we are expecting a further update to the Quality Committee in September or October for that. So I think that's a limited assurance while we wait for further information from John Jameson on that point. And then on the July meeting upward report, there is an item at the bottom which is reasonable limited assurance. So this is around maternity safety report. There are actually a few issues that are sort of tied up in there, which is why some are reasonable assurance and some are limited assurance. Some of them are more specific to NGH than they are to KGH. You will see that one of the elements within that, though, is around the digital maternity update, which I think the committee was still not where we would like to be. And I think, you know, Alice has already talked about digital more broadly as well. You haven't got it in your packs, but I have got in front of me the upward report for the meeting that we had in August. And I know that will come to you for a future meeting, but I did think it would be helpful, given the publicity and the very seriousness around the Lucy Letby outcomes, just to make you aware that the committee received an update from both hospitals in terms of the actions that they were taking forward within both trusts following the verdict of that trial, and I think specifically in relation to a letter that all organisations have received from NHS England, being very clear about the expectations that they will have in place robust systems for staff to raise concerns, because I think it was very clear in the aftermath of that incident that there were concerns by a number of clinical colleagues that for various reasons were not appropriately heard and acted upon within that organisation. So we received an update on the actions that were being taken forward. My understanding is that for KGH, that's being led by our Director of Nursing, Jane Skippen, and I think we are expecting a further update on that when we get to the next board. I don't know if Debbie wants to add anything to that, but we were assured that appropriate actions were taking place on that.
Thank you. Anyone want to come back on any of that? Rashmi.
Yeah, it's just that probably indirectly related to, you know, the ways the Skylock that we have current situation. There was some news about one of the nursing that there's some legal challenge of what I know you can't talk about it, but I just wanted to know that what is the impact and how it is, you know, been communicated in a press term, because it is we sometimes raise this issue about whether the staff is still working within the trust, and we have got this. So there must be, if the court has upheld the decision, there must be some, you know, issue with it. I can't put it in the right term, so I just don't know where we are with that particular situation. Thank you.
Okay, Debbie, I saw you put your hand up. Do you want to cover that one?
Yeah, thanks, Natalie. So I wouldn't normally discuss individuals, Rashmi. However, that particular nurse has no restrictions to practice.
Yeah, thank you. Any other comments? David?
Yeah, a couple of comments really. The first one is with regard to the IT outages that came up in the July quality meeting, where Northampton experienced a hospital-wide Wi-Fi outage, which caused some problems. When I came off that meeting, I actually had an email showing that the theatre systems in Kettering were down. And there have been further network outages and so forth. Given the significance of IT and the growing importance of it, and if it all goes to plan, outages are going to be a significant problem. And I'd like some assurance and some evidence to support that there is a robust plan there to resolve these outages and stop them from happening. Because largely, I mean, I certainly view the work in the hospital as critical. And with critical systems, there should be a level of redundancy there that prevents this from happening. And despite assurances in the past that everything's okay, that's not what I personally see. So I would like some assurance that that's actually being addressed. In the August quality reports, there were 2 papers there, one for strategy on vascular treatment and the other on cancer. I personally found them, the presentation of them, somewhat arduous to get through. They're not presented in a way that I would typically expect a strategy to be presented. I also noticed that one had reference to a business case or business cases which had not yet been developed, and the other had nothing. There was also, in both strategies, there was an emphasis on the fundamental need for improved IT for these strategies to work, and also diagnostics. And some of this was relying on the community diagnostic program. But when you look at the IT, given the position we are, I don't think within that strategy or the strategies presented, the risks to those strategies being fulfilled was adequately expressed. And we know that there are national shortages and real problems in the diagnostic side with specialists around radiography. And I think Penny also made a comment about some of the ultrasound training and skills and so forth being like hen's teeth, I think was the comment she made. So I'm just sort of questioning the whole sort of robustness of those strategies, really, and I'd like some assurance that they are as robust as they can be made, because too often things come through, they're passed through, and then 18 months, 2 years down the road, we find that things are not working out. And I think it would be prudent to spend a little bit more effort and apply a little bit more thought and make sure they are as robust as they can be before we actually start embarking on these things. Another observation on the strategies was in terms of the metrics. The metrics all seem to be process related. I didn't see anything there specifically in terms of clinical outcomes for patients, which bothered me a little bit, because at the end of the day, that's what the whole thing is about. While the process metrics are important, I don't think they should necessarily always be used as proxies for other things, which I think is what they are being used as. So I'll leave it there. I'm just conscious of time. But I think
Debbie, can you try and answer that briefly, or do you want to come back at a later meeting? Because that's a very broad question, isn't it? And
yeah,
I'm conscious of time.
Yeah, no, I will one-liner. So these are strategies. What comes next, David, is the work plan associated with the strategies, and then business cases if required.
Yeah, can I just throw another observation in there very quickly? I understand the typical process and linear process that you go through on this, but I think, in my experience, strategies and successful ones are a creative process, and they are multifaceted, multi-perspective, iterative, and they consider many of these issues before in the round, long before you actually get into the planning of the detail. And I suppose where I'm coming from, and I'm quite happy to be convinced otherwise if I've read it incorrectly, I don't see that level of thought having gone into these at this stage. But I'll leave it there because this is.
Yeah, I'll come on to that. I'll come on to Natalie in a minute. But it seems to me that, given the remit of the governors, the question really should be: how does the NEDs reassure themselves that the approach to strategy and the strategy produced are robust? It seems to me that the two key remits for the governors is, one, to hold the NEDs to account, and secondly, to reflect the views of their constituents. And it seems to me you're asking a really important question about how the NEDs make sure that they're getting the assurance that you're asking for, I think, David. And I think it would be worth coming back to a future meeting on how we do that, really. But Natalie, do you want to come back on something, on anything?
Yeah, so I recall the discussion that we had, and I think there were some important questions, I think, particularly about how colleagues are trained in developing strategies and the support that they have with that. And we did have, as you say, an important discussion about the difference between kind of strategic direction, but that being rooted in some kind of deliverable reality. And yeah, it was an interesting discussion, but I do think it's an important point. So thank you for raising it.
I mean, what I'd like to suggest, Debbie, is I think this is really quite a critical point that David's raised, and I think we ought to just bring an item back to a future meeting. But how do we make sure that how do the NEDs reassure themselves that the production and the delivery of strategies are really robust, which and therefore to be able to answer through that some of the questions that David raised. Is that okay?
Yeah.
I think that probably would be a reasonable thing there. A couple of hands have disappeared, so I'm assuming that's all the questions on that. So that's fine. Can we go on to the audit committee? Alice, is this you?
It is, John. Thank you very much. I think the report, as in the pack, pretty much stands alone, but I would just, I guess, sort of highlight, this was a June meeting. It's quite a long time ago now, but it was the meeting at which we largely receive our annual assurances, if you like, and approve our annual reports and accounts. So it was a meeting of annual updates, if you like, largely looking back over the last year and assuring ourselves as to why we are comfortable about the overall financial control environment and clinical control environment for the trust as a whole. So there are no issues that I would bring out. I think it's good news, particularly in terms of the internal audit view, that they had no concerns about the control environment of significance this year, and we're happy to give a positive overall annual report. And also on the counter fraud report as well. I think from this and other roles, I'm definitely seeing we're getting an increase in fraud attempts at the moment and an increase in cyber attempts at the moment, in both in the financial sector and in the public sector as well. And it was a good, therefore, to see that particular assurance on the counter fraud side, and also on the cyber security side, where we had an internal audit report published recently as well. So that would be last time's report. Again, we have had a meeting last week since this report came out. I think the only thing that would be a live issue to flag from that would be what John referred to earlier in the meeting. We are in the process of finalising the value for money report with Grant Thornton and providing some final evidence for them this week, and finalising that. As soon as we have a final report on that, we will share it, of course, with the governors. I think it would be fair to say, as we said at the June meeting, that across the whole NHS, those reports are more challenging in terms of the results they are showing this year in the current environment. So whilst we'll wait and see what the final report says, I would sort of want to prepare the governors that we're in a worsening climate, if you like, in terms of that report. And the report itself makes reference to that and what we're seeing in NHS trusts across the country, to set some context for our report here locally. But happy to take any questions.
Thank you. Mabel.
Thank you. I think Alice has given a very succinct and very focused summary of it. There was some discussion about the placing of the final document before government, and we're still awaiting that to be, shall I say, fine-tuned.
Yes.
Going forward, there was some discussion as well about appointment of auditors and some issues, because obviously with it being a group model, then Northampton General Hospital isn't in the same position as us, as obviously the governors at Kettering are responsible for the appointment of auditors. So that's something to look to for the future. And I think going forward, you need to involve the governors more. But I think Alice has given a really succinct and good report. Thank you.
Thanks, Mabel. Andrew? You're on mute, Andrew.
Can you hear me now?
Yes,
Yes.
certainly.
Yeah,
Thanks.
great. Yeah, thank you very much, Alice, for a very succinct report. Just what these cyber attacks, do you know where they're coming from? And do these people, do they want money or do they want data and information? And my other point is, sadly, all these junior doctors and consultant doctors strikes, they obviously have an impact on the finances. I must say, personally, I'm very, very disappointed to hear of doctors going on strike, but that's another matter. And is there any way you can compensate for that? Thank you.
So on the first point around the cyber attacks, Andrew, we're not necessarily seeing an increase here locally, just to be clear, but I know that across the country, if you like, we are. They are ultimately, I think, always after money. They are sometimes after data first as a means to money, but they are ultimately always after money, I think, sadly. In terms of the point on industrial action, that certainly had an impact, I would say, more in the current year we're in at the moment. I'm trying to think whether they started before April this year. I don't think they did. Did they? Debbie's nodding. Yeah, but they have a particular impact this year. Yeah, I think. I don't think, although Debbie would be the person to answer that there's any sort of reimbursement from the national coffers, if you like. Unfortunately, we are tracking the impact of that though, because it feeds into our planning process and how close we are to achieving our budget going forwards. Obviously, we want to understand what element of that is not directly in our control because it's due to industrial action. Is that fair, Debbie?
Thank you very much.
Right. It was the nurses that started in December last year. Yeah.
Thank you, Alice.
Thank you. I've got a couple of more questions on this item, and then we do need to move on. David.
Yeah, just a couple here. Actually, forget it. I will. I'll.
Are you sure?
Yeah. Time.
Okay.
Okay.
Don't worry. No, that's fine. Okay, David. Mo.
Thank you very much. Thank you, Alice. Can you insure yourself against these cyber attacks?
Insure ourselves?
Yes.
That's a very good question. I don't know the answer to that, Mo. I don't know what our indemnity insurance would cover in terms of cyber. I can check that and come back to you.
Thank you. Thank you.
Yeah, we'll do.
I mean, I think it's good to check. My limited experience of this is that even if you can, there are so many caveats as to what doesn't cover. And given the state of NHS digital stuff, as we've already said, I suspect that we would probably fall foul of some of those. But it's worth checking. It's worth asking the question. Sorry, Absolutely. David. Back to you then. Thanks.
Yeah, I've narrowed this down to one question. At one of the previous audit meetings, I raised the question of what internal audit actually does, and raised the issue about external suppliers and how they are actually audited, tested, and their performance against contractors ensured. And I'm just curious as to how the NEDs actually ensure that all these contracts are being performed in accordance with the contractual arrangements and to performance. What they are doing to actually look at how those T's and C's could be reviewed and improved, and what role internal audit actually plays in this, because I maybe incorrectly I picked up from the responses that is not something internal audit does. So I'm curious as to how if that is the case, how do the NEDs ensure that these suppliers, and there are a significant number of them, actually meet their contractual arrangements?
Alice?
Okay. There's a couple of places I guess that would come in, David. It's not a simple answer, unfortunately, but that would come in through when the internal audit look at the procurement department, because they would, particularly at a point where we are looking at reissuing contract, they would look at performance under the previous contract. But I appreciate that is slightly after the event, so take your point on that. They would also look at it, I guess, where they were auditing a particular area. They would look at any significant external contracts, sorry, within that area that they were focusing on. It's not something we've specifically asked them to look at as a whole, but I'm happy to check whether it's when we last looked at procurement and confirm that with you. But that's how it would come in, I would think, normally, because we would have so many external contracts. We wouldn't do that necessarily as an audit on its own per se, because it would be huge and far too wide ranging. But I think we would look at it when we were looking at particular areas such as digital, for example.
Okay. Thank you very much. Can we move on to the Group Finance and Performance Committee? Damien isn't here, but Graham, are you able to feed back on this?
Morning. Yes, a long time ago now. You've got a couple of things that were limited assurance in the papers, discharge of patients and financial position. They had a long thrash on that, and there were a number of concerns, and I think that went to the board, but it's not changed, has it? There are several other things. They went through the IGR at length, and I can assure the others that the various NEDs were questioning considerably and giving their input. Then there was the finance report. There was a lot of concern, and the annual efficiencies plan, and there was concern on both of those. I think we've mentioned already that there was likely to be a deficit and likely to the efficiencies not be achieved. There was the state's compliance report that had some limited assurance. There was one thing, I mean, it touched on what we're just talking about, the control of contractors. I mean, contractors coming in, there's only an interim solution to control them. Of course, you know, if you're an electrician, you may not have a DBS, but they're going to, with building work, there are going to be a lot of contractors around. There's a backlog of an estate survey. The survey of the estate was 7 years old, so there was a bit of concern as to how that was. But there was a high degree of challenge and a high degree of conversation, particularly about the finances and the efficiencies. And I think some things went back to the board on that.
Thank you. David.
Yeah, I just wanted to sort of ask any of the NEDs present, actually, what assurances do they get and what controls are in place to ensure that the budget process is actually robust? Because one of the questions that I ask myself when I read these packs is, how solid is this? And over the 3 years I've been involved with the governors, on numerous occasions, I've read stuff in the packs and then subsequently nothing's played out according to what they had been predicting. And I was particularly drawn to the exercises that Debbie's been running with Damien in terms of going to staff and asking for their ideas on efficiency gains and so forth. And it raised the question in my head, what was going on during the budget process? And I'm just curious as to, you know, are the NEDs, do they have the assurance that that budget process is actually as solid and as robust as it needs to be?
I'm not sure who we'd ask, possibly Alice, but whether we go back and ask for that to come back to a subsequent meeting.
Yeah,
I don't know if you want to add anything,
question.
Alice.
Yeah, the only thing I would add is that's very much the topic of one of the areas of the value for money report. I think it's absolutely fair to say that the budgeting process at the moment for NHS Trust is extremely challenging, and therefore we are sometimes asked to meet extremely challenging targets, and therefore there is not always the time we would like at the time to put in place all of the detail about how we might achieve, for instance, in this case, efficiency savings, and we are inevitably required to therefore build up that detail slightly after the event. Therefore, that is not, if you like, a perfect purist budgeting process, as I would love to see, David, but we are hamstringed by the NHS processes at the moment. But that issue is talked about in the value for money report and called out by Grant Thornton. I don't think we're alone, though, sadly. Not that that's, I'm not saying that from a complacency point of view.
Okay, I have one question with regards to some issues that John raised at a previous meeting, where he was explaining they had some difficulties with regard to accounting for group costs. And I just wonder if you could give us some assurance that those issues are now being resolved.
Yeah, can I just say on that, I think as part of the work we're doing, we are looking at the overall leadership costs across the group, and we'll be coming back with more information on that. I think, you know, given the state of the finances, we have to do that in all areas, and certainly we should be doing that on the leadership costs right the way across the collaborative. So we'll certainly be coming back to that, David.
Okay, thank you.
Thanks. Ashley, can you try and be very quick? I'm sorry if I'm getting impatient here, but I'm conscious looking at the clock and looking at the length of the agenda and getting a bit worried. But I always do this. Over to you, Rashmi.
Yeah, again, we're talking about the group budget, looking at it, how it is, in what relation do we have part of the ICB to have that across efficiency, because we should be really talking not just as a group, but also we are directly or indirectly connected as part of the ICB. Yeah. So where is that relationship? Thank you.
You know, I think you raised two important questions. The first is the ICBs are required to make 30% reduction in management costs this year and next year. So that's quite a significant thing. But I think there's also scope to have much more integrated governance with the ICBs and look at what the potential there is to become more efficient. So I think both those things, yeah, we are having to look very carefully at the overall cost of management across both the ICBs, but I think also across the group and the trust. So we'll have to do that as part of the financial agenda we've got. That's of course, you know, something you've got to balance up, because you've also got to have good management. So we'll be able to bring some of that back to you as we develop this work. Okay. Thank you. Group People Committee, Sheila.
Sorry, there was another finance committee in July as well as the June.
Oh, sorry, Graham, I missed that. Yeah.
I won't, in the cause of brevity, I won't repeat the finance annual plan efficiencies and IGR stuff, but there was a couple of extra things on that one. And Debbie might like to comment on the medical bank rates. I think she's had a conversation with Damien on. But also there was a report on the CDC business case, and one on we've just been talking about the ICS deficit control, so they were talking about that, but also on the robot benefit realization, which is something that there was a considerable talk about, and there seemed to be some issues with the business case, which they were critical of, and it turned out to be done in very short order. So that's something that maybe they'll return to, but it's obviously something quite important. I'll leave it there because of time.
Debbie, do you want to come back on any of that?
Yeah, just the medical bank rates, I think. So the conversations with regards to medical bank rates are currently ongoing. There is not a national medical bank rate, unfortunately. So we do have local hospitals who are paying more than we are, and NGHR. So we're trying to align some of that without increasing our costs significantly. So ongoing work.
Okay, is that everything, Graham? Sorry to try to cut you short. Sorry about that. Okay, can we move on to the Group People Committee? Sheila, Deborah's not here, I don't think.
No, I am.
Oh, you are? Oh, sorry. Oh, there you are. Yeah. Hello, Deborah. Sorry.
Hello, John. So we've had two meetings since we last presented these, and we've changed the format of the meeting so that we can have greater discussions in those meetings. We were just looking at piles of data and not really getting to discuss anything. Across the two meetings, you'll note the CPO report, Chief People Officer report, and attraction, resourcing and retention, employment relations. These all gave us reasonable assurance. I think the one thing that came out of all of these is that we do understand our challenges and we have plans to mitigate, but it's clearly that the challenges we're experiencing with staffing relate to the perception of what this is like as a place to work. And I know when I arrived, Debbie was talking about racism, but culture is really key here. And to that end, at the strategy meeting, which is in October, we are going to focus on our approach to culture, and we're looking at the NHS workforce plan and the EDI improvement in plan. There were some challenges around the timeframes regarding the EDI improvement plan, and hopefully we're pushing forwards on those because of the challenges. So, for example, all board directors that have an objective related to equality, diversity and improvement, and it was down to be for December. That was the national plan. We're going to move that forward. We can do that. We are committed to working on this plan. With respect to, we had some substantial assurance around gender pay. Our understanding of where we're at and our approach we felt was very strong. Our volunteering report, I nearly mentioned, the report was absolutely wonderful in every aspect, not just the data, but the narrative. And the committee were really clear that was it not for the volunteers right now, we would really be struggling as an organisation, actually as a county, I suspect. We had our medical appraisal and revalidation annual report. We were assured that the appropriate processes are in place to support revalidation, and that where there'd been any slippage with any individuals, that they were being supported to ensure that that was dealt with. I think the overriding message out of the committee has been culture. Culture, freedom to speak up. That is also going on our strategy day. It is not just about whether we can speak up. It is also about how people are heard when they do. So we will be reviewing that, obviously in the light of Lucy Letby. But just to give some assurance on that as well, as literally just within Kettering, before the last meeting we had arranged, and before the outcome of Lucy Letby, we had arranged to meet with with Catherine Wills and John Jameson, and we've also spoken to Jane about how we manage when people do speak up and how we manage investigations and what is our approach around this and how are we triangulating information. And we organised that before the outcome of the Lucy Letby inquiry. So those conversations are ongoing, and I am reasonably assured that we are moving in the right direction, and that once we've had our strategy day, I would hope to say that we are substantially assured on that particular front, that we understand the situation and that we have plans in place to ensure that we continue to be strong. I saw a hand go up.
Mo.
No. Oh, hi. Thank you very much. Two questions, really. Do you have enough consultants trained to do appraisal to their colleagues, or do you employ outside sources for that? The second one is, how do you select your volunteers, and what kind of strict methods you apply to them, and make sure that they are useful and not causing any trouble? Thank you.
No. So the appraisal process, yes, we have sufficient people trained, and that was in the report. Then I think on average not doing more than 5, and I think that's reasonable. In terms of the volunteers, we have a recruitment process. Obviously, they have to be recruited in a similar, and it's not like the interview that I or you ever had, Mo, but it is about ensuring that the right processes in the background are followed, so that DBS is completed, and so our volunteers do have a recruitment process that reflects what you would do for somebody who is going to be employed. And I'm not aware of any of them creating mischief, but I'm sure we now have a culture where people are speaking up, and that would be, we would investigate that if it happened.
As long as they are smiling and safe, that's Great thing.
I
Thank you.
do talk to them. I do wander around the hospital and I do ask them how they are, and I unequivocally get good reports from them. So thank you.
Sheila?
Yeah, I just wanted to say that I agreed completely with Deborah's report. There's always a lot of discussion going on at the People Committee, and I think the areas where we say we're reasonably assured just means that we know work's being done, but we're monitoring how it's going. And that is good. But I also agree with the speaking up thing. It is difficult for some people to speak up. And Deborah's quite right too. We sometimes listen to people and we don't always hear what they say and act on it. And that maybe is something that will be ongoing forever. There's always somebody who needs that little bit of extra encouragement to speak up. Can I just tell you a nice story about staff who are happy at KGH? I have known one of the housekeeping staff for many years. Always greets me like an old friend when I come into the hospital, and she is retiring. I'm not leaving, she said, because when I retire, I shall join the volunteers.
That's good. Thank you. Rashmi?
Yeah, just with the volunteers, I just wanted to know that, like you say, we can't do without volunteers, but how and in what way we really invest in them, in the volunteers, to respect and value, because we all, as when you do governors or anybody, we directly, indirectly, all volunteers, and how are really seen as a volunteer investment policy, because sometimes I see we don't invest in the volunteers, how much we get out of them. Thank you.
Rashmi? I think you're absolutely right on that. I think one of the ways is to make sure that we visibly show our appreciation to them. I'm not sure how it works here. I'm sure there are various things that allow us to do that, but I think that's critical. But I think that what you get back from volunteers is huge, isn't it, Deborah?
Absolutely. And to that end, I met with the governor. I've just forgotten, I'm rubbish with names. I've just forgotten the name of the governor who's a volunteer. And she's going to do some work with Emma Wimpress, who presented this report on how we can improve our response to volunteers, Rashmi. As John says, we express our gratitude, and this went to board for that very reason. But equally, how can we do other things to make them feel welcome? Mabel.
Thank you. Mabel?
You're on
Mabel?
mute.
Sorry.
All right. Yeah, you're there.
Thank you very much. That was a very nice report. I've not read the report about volunteers, but one thing I do find is nobody realises that as a governor, I am also a volunteer.
You are, yeah.
For all the other governors. And talking to some of the other volunteers, they say, oh, we get T-shirts. We get absolutely nothing but our expenses. I was thinking about what I've ever got. I was once, not how many years ago, it must be about 6 years ago, I got a tin of biscuits. That's been my lot. I can claim my expenses, but I don't think people realise that we are volunteers or appreciate that we are volunteers or the work we do. As I say, we've asked for T-shirts, we've asked for fleeces, we've asked for badges, and I'm sorry, but we have had nothing.
Mabel, do you mean as a governor, or do you mean as a volunteer working on the ground?
Are volunteers.
But they wear T-shirts. I was with somebody yesterday.
Even have a T-shirt when we say go out to a community event, say we're trying to recruit members to in the future become governors or whatever, we have nothing.
As a governor, you're suggesting. Yeah. Right. Okay. Sorry, I do apologise.
Deborah, do you want to come in on that?
Yeah, thank you. Mabel, thank you. I'm sorry, I didn't know any of this. So please leave it with me with regards to T-shirts, jumpers, fleeces, thank yous, etc.
Thank you.
Thank you, David.
Yeah, I just wanted to ask a question around analytics in the people side of things. Deborah, do you feel that the systems and the data that you've got access to are sufficient for you to run the analytic models that would give you more of an in-depth insight into some of these issues that are going on the people side? I mean, one of the issues that's been discussed, for example, is the racism and so forth. And Anu talked about different working patterns and so forth. I mean, that's an obvious one that you could sort of look at. And there are many others that you could put in place to look at in terms of how people are actually performing and where these things are outside the norm. You know, a typical one would be actually tracking absence by supervisor and manager and so forth. So as that manager or supervisor moves through the business, you can see how they're going, etc. So I'm just curious, are you comfortable and do you feel that you actually have the tools and are the tools there, in your view, being used as well as they could be in order to support the activities of the trust?
Sometimes, John, sorry, David, I'm looking at John above you. Sometimes and sometimes not, and we have challenged. So difficult to see from these, but you can see it in a couple of the paragraphs that we have challenged around data. So, for example, with absence, we felt that at Kettering we weren't getting as much data as we would like. We were seeing sickness absence, but we wanted to understand other absence, so parental leave, and it was just down as other, and we wanted to know what that was and when it was occurring. And so hopefully that's going to be more explicit. And I was having a conversation before I joined the meeting, which is why I was late, about with HR, and I do sometimes think we use a proxy measure. I heard you saying that, David, when I arrived, and so we are working on it. But what I have to say to you is that these are very good conversations with our colleagues who do produce the data, and we have been working on different types of meeting for these past 3 meetings so that we strengthen, one, the discussions, but secondly, the reports that are coming and that the data is better. And we're going to do a final review of these 3 meetings because we've got another one very shortly. And we are all in agreement, colleagues who present and the NEDs and the governors, that the data is getting better and it's helping us to understand and helping us to challenge. But thank you for your question, but we are moving on that, and you're right to ask the question. Am I assured? I am reasonably assured at the moment. If our data was broader and sometimes more direct and looking at the problem we want to look at. So, for example, learning and education. We just got told there was, I don't know, I can't remember the figure, 96, 97%, everybody was done. But we knew there were problems with life support. And we went, where is that? Not only where is it so that we can challenge those teams, but why aren't those teams compliant? Is there a problem in those teams? Is there something we don't understand? So we are asking for it, David, but thank you.
Okay,
in a short statement, David, the NHS is woeful on good, meaningful information to help support management and decisions, and consolidated, coordinated decisions are information to support, and more holistic information to support clinical care. And those are 2 things which there have been over decades not enough investment in. And I hope that with the digital thing, we'll start to see some of that coming through. So I think, whilst I take Deborah's points, absolutely, I think we just need to recognise the NHS is a long way off the curve of other sectors in this. Right, Jane, this is the last one I'm going to take on this topic, and then I'm going to be quite brutal going forward because we're 25 minutes behind, and I'm only a little way in the agenda, so we are going to have to really accelerate it a bit. Jane.
Okay, I shall be quick, Mr. McDonald.
Thank you.
Deborah, nice to see you. Talking about how people don't speak up and how you can reach them. Coming on to Let's Talk, you're either visible or your voice is heard, so people can identify you. Going to see Debbie, obviously one-to-one, Debbie then meets a person. when you go into any department, usually as a patient, you're usually asked to fill in a questionnaire about how we did and put it into our comments box. Could we have something similar for that? Because even if a nurse or a doctor wants to send something questioning or report something by email, you can track emails. So how about a complaints or suggestion box for staff to put any suggestions or complaints or anything like that in a box that makes it totally anonymous? Maybe that make them feel more comfortable about speaking up.
Deborah, you're on mute.
Oh shoot. Sorry, I think there is a mechanism for doing it anonymously, but I will check, Jane, because I'm not 100% sure.
Thank you. Group strategic development, because there's no one here on Digital and Transformation Committee. So Graham,
I was there at Digital, so.
Oh, you were, okay. Thanks.
I'll be very, very brief. I think the report there is absolutely shows the breadth of stuff they talked about. There were two non-execs there who did their Trevor and Andrew questioned deeply as usual and very thoughtfully. There's one small item that governors may be interested in. There's an issue with regarding a delay to GP letters being sent out. This turned out to be an external issue that had caused the problem, not internal. And it seems to have been resolved anyway. But so governors getting with their sort of public hat on may get some comments. That's my lot.
Thank you very much. Okay, shall we move on then to item 6?
Sorry,
report from the group strategic. I've forgotten that. Sorry, Graham, you again. Yep.
Yeah. So once again, reports on development. I'll be brief. The only item of, I suppose, concern is the new government limits on the programs, the business plans, which have an effect, and I think that's still being worked through. But everything else is there.
Thank you. I mean, I do think it's a very difficult environment for this agenda at the moment, isn't it? With the sort of financial uncertainty, political uncertainty, etc. So I think this is something that we just need to keep a close eye on.
I think governors may appreciate an update on how it's being reworked.
Yeah,
I think probably the answer to the position to do that yet, but when they are.
Well, no, I think certainly just very quickly. I mean, my view is that we're not going to get lots of decisions made in the next year or so. We are one of the first wave trusts, and what we have to do is develop the plan so that whatever happens in the future in terms of the financing, the priorities and everything else, we've got an absolute cast iron case for development, because I think there's a lot of uncertainty looking forward around this program, not just for Kettering, but across the whole program, really. Okay, thank you. Shall we move on to item 6 then? Mabel, I think you're going to present this, aren't you?
Yes, thank you. I'm afraid Peter's unwell, so you've got me. I will be very succinct. We had a lot of discussion and we approved the Vice Chair's remuneration, and also we had a lot of discussion about the creation of Associate Non-Executive Director posts, and we felt they were very useful because they enabled people to have almost a training appointment, and also the appointment process with NHS England is very laborious, and I gather they want to be more involved in all appointments. So I think that will expedite the timescale. So on that, if you're happy with what I've said, I will shut up.
Right, any questions on that from anybody? So can I take it first of all that we agree the increase the Vice Chair's remuneration to £25,000 a year, and also the creation of the Associate NED role? Thank you. Item 7, the appointment of interim Chief Executive and Accountable Officer. Richard.
Purely to note the Governor's decision that was taken by electronic resolution, Chair. Thank you.
Okay, thank you. So we'll note that. Yeah, Mo.
So there is a chair, vice chair, and an associate vice chair, is it?
No, the associate is just a non-executive director, not a vice chair. There's a
I
chair,
see.
which is myself, and there's a vice chair in terms of that as well. Yeah.
And the associate?
The associate is just a normal non-executive director. They're not a vice chair.
I see. So his job description is that he's an NED.
Yes, associate NED. The only difference between associate NED and a NED is that the associate NED does not have the vote should the board ever require a vote. Other than that, they play exactly the same role.
Thank you very much. Thank you.
Thank you. Okay, item 8, Mabel, again, I think this is yourself, report on the community engagement group.
Thank you very much. The community engagement group, we have got new terms of reference. I won't go through them in detail, but they are there. They're kept very succinct and they can be adapted. I think the community engagement group, the group has been very, very vocal. It's been a very lively group, but we can't really plan for any future projects because obviously we've not had a director of communications long term. We did meet with the lady who's on maternity leave at present and looked at some projects, but we're looking forward to meeting with the new one and working on projects. I think that as a group we talk a lot, we take forward some of the items we talk about. The other things that we tend to do is we are the eyes and ears of those we represent. We feed back things on maternity, children's services, all sorts of issues. Blood testing last year, we did some work with that. So we're quite lively and take forward things quite often. And the other thing that I feel that needs to happen is the group does need to be revitalised. My term of office as a governor ends in December, and I'm keen that this group continues, but it needs to be more attuned to doing some work going out on health promotion. We've been very successful on one area. We bring in lots of speakers for outside. I've got a queue of people who want to come and talk to us, but I feel we're almost an elite little group, this group. So I've suggested that those speakers go to the main group of governors. Last time we had a talk from a lady from Headway, a little charity I knew nothing about, and it's for people who've had head injuries like strokes. Very vibrant group, meets in one of the local libraries. I've personally already referred a neighbour to it. So very, very positive outcomes with our group, but it needs to be wider. So I think that needs to be much wider. The other thing that's been very positive is that many of the speakers, Sue has taken those forward and made them the basis of some of the seminars that are produced for people generally. So it does broaden, but I think we need to broaden things more. And I'm conscious of time, so again, I'll shut up.
Thank you, Mabel. I mean, I think you make some really important points there, Mabel. One of the things that the developing more collaboration within the integrated care system is that actually we need to get as a trust much closer to communities than we have, and that's not being critical of Kettering. I think that's all trusts need to ask themselves that question across the country. And I think that one of the things we'll be doing is we should be doing in the next few months is giving some serious thought about how we really do hear the voice of the community and how it really can play a major role. So I think the points you've made are really important, and that is something which we'll be picking up. And I think the role of this group will need to be part of. We need to look at what the role is in that. So I think it's something the trust all acute trusts have been not very good at engaging their communities, if I'm honest. I'm sure there's a few exceptions, but I can't think of any. So I think that's something we want to be doing in the future.
Thank you. If I could come back for some points. I know a lot of ambulance drivers. And also around Christmas time, having on occasions brought people to an A&E. The main cause of people visiting A&E is inebriation. I begged and pleaded for something to be sent out about alcohol, taking excess. Richard May carefully helped me draft something, and we tried to get our communications department engaged so she could have this real push out about what to do if you drank too much, that you don't call the ambulance, what to do, how to put people in the recovery position, basic simple things, how to drink sensibly. Couldn't get anything done at all. So I really do hope that going forward something can be done. And so I'll shut up now, as I said.
No, thank you for that. Thank you, Mabel. David?
Yeah, I'd just like to echo some of the points that Mabel made, really. We set this group up a while ago, and it's been a bit frustrating, as Mabel says, largely because we haven't been able to get any sort of real sort of uptake with the communications arm of things within the trust. I think one of the things that came over to me was that a lot of the people in the group were also involved with patient participation groups. I chair one, Peter chairs one, I know Sheila's involved, Simon's involved, there's quite a few of us. So we've got quite extensive links. I've spoken to the library in Corby, for example, about using facilities there and using their website as a communications channel. I've spoken to some of the schools about doing stuff with their sixth form and so forth. But I think we actually need I think what we're lacking is a trust strategy on this, as you say, John. If we could get that, I think there would be a huge uptake from the group because we're all pretty well connected anyway. The one problem that we would potentially face occasionally is that people turn around and say, this is a public health. That tends to be the excuse at the moment. You sometimes get this kickback. It's a public health issue because what we're talking about is communication, education, and so forth. How to use the services, how to take care of yourself, etc., etc. So there are a few hurdles, but I think, you know, with a bit of a strategy there, I think we could do significantly more.
I know, I absolutely agree with that, and it's quite sobering if you think that 80% of people's health actually has nothing to do with the NHS.
Yeah.
It has to do with, have you got a job? Are you eating well? Are you exercising? And I think we could do far more than we've been doing. And I thought all acute trusts, I'm not being critical in any way of Kettering, I think all acute trusts have to be asking themselves that question. Deborah?
I've just been looking, and the BBC did a report about Kettering and how there's a vehicle at the end of an evening when the clubs close that is there to keep people safe. And so maybe if you could look that up, Mabel, and find out what the name of it is. But it's funded by a charity, and they are there to make sure that people get home safe. And it does tackle the issue of inebriation in terms of keeping people safe and not ending up in hospital.
Thank you. Rashmi?
Yeah, I just want to again emphasize the point you're talking about, the community engagement, and you also mentioned about the ICB and ICB taking lead and having this strategic partnership within the organization, because we are all the time talking about it, but we are not doing the work. And I cannot emphasize, because within the public health, within the the ICB, all different partners, we are not investing enough, and we keep on talking about, and we cannot expect without resource investment to get a preventive strategy. So unless you are really going to, as an ICB, take the lead, this will continue as a talk. Thank you.
Thank you. Sheila?
Yeah, I don't know if everyone's aware, but I'm vice chair of the East Northants PPG Association, and there are 9 surgeries. I think it's the biggest PCN in the county, and we do go out and talk to the public. But more importantly, we have a connection with James Gillespie Allen, ex Kettering, and now ICB Comms and Communication. And he's trying to set up a network across the county allied to the PPGs in the GP surgeries, because after lots of discussions between us, we thought that was one of the good ways of reaching a lot of the community. And I'm just wondering, there are separate things going on. Could there not be some collaboration between the hospitals and the Integrated Care Board?
Absolutely. Yeah.
I mean, they seem a bit isolated. For instance, Healthwatch produced a whole number of reports we used to send to the old CCG, and they would write a response. We were sending reports to the new ICB and were getting no response at all. But when queried, they said, "We don't do responses anymore, but thank you for the information." And I find that a very
I find that very
lack
strange.
of communication. It's sort of isolating them. And I've been used to talking to individual people at the CCG in the past. Now you get some generic address and you get this anonymous sort of email back, and you can't actually speak to the person you want to speak to. And I find it very frustrating.
I'll take those comments back, Sheila, to the ICB, because you're absolutely right. This should be an integrated approach, not a discuss.
Absolutely, yeah. I think it should be. I mean, we are supposed to be integrated care, aren't we? Yeah.
Graham?
Thank you. 3 things. First of all, NNC has a health scrutiny board, which I happen to be on. And if Mabel or anybody wants to come present to that at any time, that's fine. We're pleased to see you. Secondly, there's a new public director of public health started last week, Jane Bethia, and I'm sure she would be pleased to engage with the governors at any time. And there was a third thing which the bus. It's called a snow van, Safer Night Out, and it's run by Kettering pastors, the night pastors, and in conjunction with the Northamptonshire Guardians, which is a woman called Sue Goodship, and it's funded by the Police and Fire and Crime Commissioner, but it only operates certain nights. So, but it is there, and that's how you get hold of it, through the Kettering Street pastors.
Yeah.
A lot.
Thank you, Mo.
Thank you all. I thought that the Department of Education should have a role in this. I mean, they teach people safe sex. Why can't they teach them safe drinking as well, and safe going home, and all the rest of it?
I think lots of departments have a role. Housing has a critical role in this, education, etc. And that's a bit about integration. You know, it isn't just about the NHS doing this. In fact, you know, we need to be supporting the local authorities in this, rather than thinking we're leading this work because of the wider determinants of health. So I think you're absolutely right, Mo. Mabel, last comment from Mabel then.
Thank you very much. I'm so pleased to hear your enthusiasm for this role. The governors do an awful lot. We would like some more resources. I've asked for T-shirts, we've asked for coloured paper, all sorts of things, and are always told there is no money. And, you know, lovely support from Richard May and his staff, but by the same token, you know, you feel a bit silly standing outside some event or other just with your lanyard on. You have got nothing like a T-shirt or a fleece we've got nothing to show who we are. We've got no material, pop-up stands, nothing. We used to have it. We used to have a lady who was a governor who engaged with all of the GP services. She was absolutely invaluable, and that post would be well reappointed. I'll shut up again. Thank you.
I think Debbie's promised to look into that, haven't you, Debbie? So that's fine. Thank you. Right. Can we move on then to item 9, which I think is for information? The report from the ICANN People Advisory Group. Rashmi?
I think it speaks itself, you know, so I don't think there's
Okay.
explaining enough unless people have got asked, and I'm sure Sheila also attends. So, you know.
Anybody want to come back with any comments on that? Mabel, is that a legacy hand?
It's a legacy hand.
Okay. Don't worry. Thank you. Okay, fine. Shall we then look at the report and propose recommended schedule for face-to-face and online council of governors meetings in next year? Richard?
Take the report as read, John. This is a response to governor's feedback. Conscious we've been online for the best part of 3 years, and there's some value in public and some internal value in moving to maybe a mixture of online and face-to-face meetings. Hence, that is the plan for next year. Thank you.
Thank you. Any questions on this? People feel it's taken on board their comments? Thank you then. The proposed abolition of the trust board, the governance overview group and secretary establishment of Meet the Governors Forum. Richard, is this you again?
As I say, yeah, in Peter's absence, Peter's led the work on this, but the report sets out the context that we set up the overview group at a time when engagement between governors and non-execs wasn't where we wanted it to be. We've made some good strides on that over the years, to a point at which actually the agenda for these public meetings and for the overview group meetings have become duplicated and the business blurred and a lack of clarity. So we're proposing to create, again, following on from the engagement discussion that we've had, we hope this will enhance two-way engagement and understanding between the governors and between the hospital, and help the governors to hold the non-execs to account for some of the issues that have been raised today, for example, the strategy question. So that is the proposal, that we replace the overview group with a Meet the Governors Forum, and that we build together a work schedule of one-to-ones with non-execs and with representatives from the hospital, and potentially with external representatives as well. Thank you.
Thank you. People are happy with that. I'm always delighted to see a meeting abolished. Well done, Richard. Thank you very much. Okay, any other business? Deborah's kindly stayed on to just say a few words. So Deborah, can I hand over to you?
You can, John, thank you. So Mabel and Mo, I can see you both. This, I believe, is your last Council of Governors meeting, having done 3 consecutive terms, so 9 years in total. That is absolutely no mean feat. So you've clearly represented your communities perfectly over the 9 years. So on behalf of Kettering General, the board of directors and all of our colleagues, I would just like to say you've done amazing work. Thank you very much for everything that you have done to support us and our patients in the community. We will desperately miss you, absolutely. And I'm hopeful, Mabel, that you will still be following me on social media and supporting as much as possible from the sidelines. But thank you.
I will miss you all too. It has been a great 9 years, and has opened up a lot for me to see the NHS from the other side. I've learned a lot in it, and it has been a great experience and a great service to our constituents, really. Thank you all very much indeed. Yes, and thanks, Mabel, for all the support and work you have done. Thank you.
Thank you. Thank you very much.
Deborah, for those kind words. But the kindest thing that happens is the thank you from some of those I represent. And I can only think of a lady I spoke to last week who seemed to have been lost in the cancer pathway for 9 months. And she has been in tears to me so often on the phone, and I've been trying to tease it through. And she rang me last week. She said, you must have kicked some bums there, because I had a phone call from the consultant and she's booking me in the next 2 weeks, and that's what it's about.
You're absolutely right. Well done. Well done. And thank you very much. I just felt, as I hadn't really worked for you long, it would be much better, the words coming from Deborah, and much more genuine, as she knows you so well. So thank you. Graham, you put your hand up. Did you want to pick up something?
Well, I did, but first of all, I'd say that Mo and Mabel have been brilliant governors, and this limit on terms sometimes is stupid and to be regretted, but there we go. And I just had a couple of points for Deborah that she might like to ponder on. I've started doing some volunteer medical driving again, so I've been to the hospital a bit more than I had recently, and since the change of entrances to the main entrance, there now don't seem to be any disabled chairs at what I'll call the old outpatients entrance, and I had somebody in a chair and I had to ferret right down to the other end, and also they were going to cardiac, and they went to cardiac investigations only to find that the place that, bearing in mind there's somebody on crutches, the place they should be in was the other cardiac at the other end. So why are they so far apart? And then sitting there waiting for them, somebody came in with exactly the opposite problem. They'd come to the cardiac when they should have been investigations. So and they had to make their way. So I just wondered why they were so far apart. And the last thing, this is something my wife moans about constantly, and I noticed it when I was sitting there. People come in for an appointment and they're asked for their innermost details, and they have to give them out loudly. The woman I was taking even had to give the phone number of her sister, who was the next of kin, give all this information out, and all the people sitting in reception could hear it, and dates of birth and all sorts of other things. Can't we? And this is not just Kettering. This happens all over the place. Can't we find a way that people don't have to give their personal information out for all to hear and see? I mean, who goes for an MRI when they don't need one? I don't know. It just seems, look, okay. It's overkill, and B, if we were doing this online, we'd be reported to the Information Commissioner straight away. So why, if we're doing it face to face, are being asked for all this information and giving it out? And I think something needs to be thought about, and that's my lot.
Okay, I'm sure Deborah will take that away and look into it. Okay, thank you. And finally, just to note that the AGM, which was originally scheduled for the 22nd of September, we've had to postpone that. Have we got a date agreed yet? I know we're trying to, Richard. Have we got a final date or not?
Not yet, John. I'm hoping for around the 10th or 11th of October, but I'll confirm that as soon as I can. Thank you.
Okay, thank you. So thank you very much for your time and your contributions. The next meeting is officially on the 6th of December. We may, I don't know, Deborah, whether we're going to have a special meeting to look at the auditor's report. I think we probably are, aren't we? So there will have to be a meeting probably later this month to make sure that you see that and to discharge a role on that. I think that's true, isn't it?
I think so. Yeah.
Thank you very much. We'll see you well before. Oh, the other thing I should say, by the way, is we are starting to look for a date to have this discussion workshop on the collaborative, which I think you said you would like to have. So we're trying to find a date of that. It'll probably be October now, given diaries, but that's what we're looking at. Okay. So we will see each other before December.
Thank you. Bye.
Yes. Thanks. Bye.
Goodbye, everybody. Goodbye.
Thanks, Chair.